Welcome to the POPMA Study Club regular series. I am Dr. Bhuvan Nagpal, President of Practicing Oral Pathologists and Microbiologists Association. And I welcome to all the participants joining us for today's session of POPMA Study Club, which is being hosted by POPMA. We are delighted to have your presence here as we continued our shared journey of academic excellence and professional enrichment in the field of oral and maxillofacial pathology and oral microbiology. Today's session focuses on a very relevant and clinically significant topic, that is algorithm for diagnosis of cysts of maxillofacial region. Cystic lesions in the maxillofacial area often present a diagnostic challenge due to their overlapping clinical and radiological features. This session aims to demystify those complexities through a systematic, practical approach that will benefit both academicians and practicing clinicians and practicing oral pathologists. It is my privilege to introduce our guest speaker, a name well known in both academic and clinical circles, Dr. Abhishek Badranna. Dr. Abhishek Badranna is senior consultant oral pathologist with over a decade of experience and a keen academic focus on oral precancer, odontogenic cysts and tumors, and oral squamous cell carcinoma. He is the general secretary of POPMA also and heads Dr. Badranna's Oral Pathology and Company, which provides expert histopathologic services for head and neck biopsy specimens. He is also the partner and chief clinician at Adis Dantalle, Bengaluru, and the director and co-founder of 91 Danta Research and Product Development Private Limited, an innovation setup currently incubated at Indian Institute of Science, Bengaluru. An accomplished researcher and innovator, he holds a patent for dental aerosol blocker, has delivered numerous national and international guest lectures, and has been honored with several prestigious recognitions, including the Best Scientific Presentation Award at the 18th International Congress of Oral Pathology and Medicine. We are truly honored to have him with us today, and I'm confident that his insights will greatly enhance our understanding of the topic. I now invite Dr. Abhishek Badranna sir to begin his presentation. Over to you, sir, and thank you so much.
Thank you, Dr. Bhuvan. Thank you for this opportunity. And I truly it's an honor to be doing this today. So not wasting much of time. So he has given me an introduction. So I hope you can see my screen, all of you.
Yes, Dr. Badranna. Yes.
My voice is clear?
Yes, your voice is clear. Anybody has any issue can share the issue in the chat box. And I request everyone to please keep their mics and the microphones and the video on the off mode. Thank you so much for this understanding. I think, sir, you can proceed further.
Yeah. So this is an opportunity to learn for me. I'll just share you a story. In Japan, what happened? Fish is at a very high demand in Japan. They're fish eaters. So there was a very costly fish that was there in the market. So what they thought is many people went into the deep sea, got the fishes, put it in the refrigerator and sold it. So Japanese people who ate these fish, they said, no, they are not impressed. I don't like it. So then they said, okay, what should I do? How should we do this? So what they did, they went and kept refrigerators within the fridge and started getting these fishes and coming back earlier. But still they said that, no, this refrigerated fish doesn't work. I can't pay you so much money. Then what they did, they bought the fish, stored it in large tanks and created a slight environment like a sea and left some sea sharks. So whenever these sharks went around these fishes swam, and whenever there was a demand, they should take this fish from the tank and sell it. So that fish was still fresh. So it is like that today. I have accepted to put a shark behind my back. Doesn't mean I know more than you guys who are participating here. I'm here to learn only. So they say teaching is best way to learn. So that's it. So yeah, cyst, coming to etymology. Cyst means it is taken from ancient Greek, which is cystis, meaning bladder, pouch, or bag. And then it entered the English language through a new Latin word called cystis. Etymology explains why cyst refers to a fluid-filled sac or pouch in the body, as well as why related terms like cystitis refers to the urinary bladder. So I think so somebody has annotated. I'll just erase it off. Thank you. Kindly avoid doing this.
I have
So
enabled, I have done that, sir.
yeah, thank you, doctor. So Kramer, this was this big definition, right? Viva is just the Kramer's definition. So cyst is a pathological cavity containing fluid, semi-fluid, gaseous contents, and it is not formed by the accumulation of pus. Kramer's definition also emphasizes that cyst is not necessarily lined by epithelium. So this was the definition that used to by heart, but now it makes all sense because this is into application that we are using today. So if anybody can tell me what is this?
This, this is the content of Schaeffer's textbook,
Yeah, perfect. Perfect. Doctor has gone through so many
sixth
times. It's one of
edition, I believe.
bingo. Okay. So if you look at it, section one is disturbances of development and growth. In that, you have tumors of salivary glands, cyst and tumors of odontogenic, benign and malignant. So there is something, there's a reason as to why the contents flow in a certain way in a textbook also. This I appreciated very recently as to why these sections were made. Somewhere, if you look at it, neoplasia is disturbance in growth or repair, something gone wrong there. So something that has to stop growing is continuing to grow. Okay, cyst is over right over there. Okay, so yes. So parts of a benign tumor, two basic benign or malignant tumor, particularly, you have two basic components. One is a parenchyma and one is the stroma. Stroma is one that has the fibrous content, the blood vessels. It supports the parenchyma to spread. Okay, it is as important as the parenchyma. Now, if you look at it, parts of a cyst, if you look, it is SRL, the camera shot of the cyst from the slide itself, not a microscopic shot. So you have a blue colored cystic lining, which we termed as parenchyma, and the pink colored connective tissue stroma. This has not been properly defined in textbooks, but this is how I imagine, and basically the label of a cyst or tumor is given from the parenchyma, right? It comes from the parenchyma. Here, in our case, which I'm talking today, is cystic lining, right? So coming back, suddenly I want to ask a question. Anybody can unmute this and say, which is your favorite fruit? Anybody can tell me? I know Dr.
Mango,
Bhuvan.
mango.
Mango. Bingo.
Mango,
Okay.
mango.
Okay, great. Mango itself. So mine, mango, but banana is the one that I eat the year throughout. It's my, like I can actually it's very favorite of mine. But mango is the seasonal fruit, right? Today, if you look at it, there is a tie between Ratnagiri Apus and Malgova. You can Google what is Malgova. It is very famous in our side. Otherwise, Maharashtra's is the Queen Alfonsa. So I made a section out of it. I wanted to do something. Compare the skin of the mango to the cystic lining and the pulp of mango to the connective tissue wall. Okay. If you look at it, this is how you need to see under the microscope to look at the cyst as well as the stroma. But sometimes we get something like this. This is a cystic lining, an incisional biopsy, and somebody has put it flat like this. And we get a uh, uh, picture like this, which is completely non-dependable. You can't depend on, we can't say anything on this. So one is like wastage of time. We'll go back to the lab, say that you have to re-embed it. So it should look like this. If you look at it, blue should be visible on one side and you have the stroma. So embedding, see, this is the skin. This is the cystic lining that stays like this. Then you have your stroma like this. That is the correct way. See, now the cystic lining is up and you're embedding it like this. There's no way that you can diagnose this case. Now you can say macroscopically, this is a mango. but this is not the way to embed. So the most crucial part of diagnosing a cyst is embedding, according to me. If you get this wrong, your diagnosis has fallen there itself. I hope all of us are on same. So what I have is like I, Sharda ma'am and Priya ma'am, we are working towards having a nice laboratory. That's Dr. Badrana's oral pathology. We have a group, the embedding person in the lab who's over there. We give them instructions. Okay. Sometimes we write like this. We need the cyst lining should be there. Even the connective tissue should come like that. And sometimes we also send them video. Just instructions ಇದೆ. So I've spoken in Kannada. Slide ಇದೆಯಲ್ಲ ಇದನ್ನ ಈ ರೀತಿಯಾಗಿ ಇಡಬೇಕು. Everybody can see the video?
Yes, yes, sir. Please go ahead. It is visible.
ಮತ್ತೆ ಇದು ಇಲ್ಲಿ ಕಾಣಿಸ್ತಾ ಇದೆಯಲ್ಲ, ಇದು ಸ್ಲೈಡ್ ಅಲ್ಲಿ ಕಾಣಿಸ್ಬೇಕು. ಸೊ ಕಾಣಿಸ್ಬೇಕಂದ್ರೆ ಈ ರೀತಿಯಾಗಿ ನಿಲ್ಸ್ಬೇಕು, ಅವಾಗೆ ಬರೋದು. ಎಲ್ಲಾನು ಸಿಸ್ಟ್ ಇದೆ ಎಲ್ಲಾನು ನಿಲ್ಸ್ಕೋಬೇಕು. ಓಕೆ, ಈ ಫ್ಲಾಟ್ ಅಲ್ಲ, ಲೀನಿಯರ್ ಎಂಬೆಡಿಂಗ್ ಹಿಂಗೆ ಥಿನ್ ಆಗಿ ಬರಬೇಕು. ಓಕೆ, so it's important to have a very clear messaging to the lab and people whom we work. Communication is the X factor in diagnosing this cyst. Okay. At 2:24 p.m., I took a screenshot. Around 22 of you have responded to my Google Sheet. 34 of you are present here. Thank you very much. Okay. So there was this question number 13, which I had posted there, and quite a good number of response. But 13 out of 22 were empty. I completely agree with you that there was something that we could not diagnose, and there were other responses as well. One was a very good response, cannot appreciate epithelial details. That's a very honest response. Okay, I congratulate that person. See, if you go, these are the other photographs. This was how it looked on a higher par. Okay, it was completely, it was degenerative. There was nothing there. Okay, so I had done a research when I was in a UG. I had taken a pig's tongue and done all kinds of mistakes in processing errors, fixation errors, and everything, and I had made a poster of it. Okay, this gave me a lot of insights as to how this histopath looks under the microscope if some mistakes are done. Okay, so if you leave something in saline for more than 30 minutes to 60 minutes, the epithelium separates out of the connective tissue. This is an actual image of the research that we did. Okay, the separation of epithelium occurs. If this separation occurs, God only should save us from diagnosing the case, right? Then you have intracellular edema that comes, the desmosomal junctions breaks off, and finally the tissue goes away. It sort of looks like, it's almost like a pemphigoid or we get this skin lesions. No, you get images like that. So the question number 13 was that only. And there's a small video again. Issue was received, which is poorly fixed. It was not in the formalin, and we can see that the tissue that has given already, you can see some amount of degenerative changes macroscopically. Here too, the structural integrity of the tissue is lost as soon as we put it on this one tissue paper. We see that it is separating off. So this will be a difficult case to visualize under the microscope. So I really thank Anita Borges ma'am, who have told so many stories in histopathology and so many things that I really every time I do some histopath, she's there on background looking behind us or something. I'm really thankful for all those things that she has shared us. Okay, so there was a story that ma'am had said, for want of a nail, shoe was lost. For want of a shoe, the horse was lost. For want of a horse, the knight was lost. Want of a knight, the battle was lost. For want of a battle, the kingdom was lost. So a small nail, if it is not put properly on a shoe horse, there is a chance of us losing the battle. This, if you compare it to histopath, is diagnosis is lost because of poor fixation, poor processing, poor embedding, poor sectioning, poor staining. All these are not there. where diagnosis is thrown out. So first, there is something called pre-analytical work. There are a lot of quality is required. I'm luckily associated with a lab called Prakash Lab who does this fixation. Fixation, we do it. We ask the clinicians to do it with formalin 10%. Then they do a beautiful sectioning and give those tissues. And I'm really thankful for them. So this is the basic thing. If you don't get this right, forget about diagnosing cyst completely. Embedding is important. Then the story was told by Anita ma'am that if you don't do all these properly, forget about diagnosis. The battle is lost. The half the battle, no, the complete battle is lost if you don't do those work properly. Then this was a case which I shared in the Google form. It was an 11-year-old female patient presented with a painful swelling associated with unerupted 3-5. Okay, and this was another case. 21-year-old female patient presented with a periapical radiograph in relation to periapical lesion, radiolucent lesion. A 44-year-old patient presented with a well-defined radiolucency in the edentulous 1-4 region. A 30-year-old patient presented with a well-defined swelling in anterior palate. Okay. So what is the commonality of all these cases that I have shared here? Anybody can unmute and tell me.
I request all the participants,
This is a two-way
those who
thing.
please
Okay.
interact.
Otherwise, me and Bhuvan, we always speak on phone. Or we
Yeah,
send
yes.
message notes. Otherwise, we can do this some other time
Those
also.
are all cystic linings.
Any commonality in that, Dr. Abhishek? In those cystic lining?
Yeah, all the epithelial connective tissue
Yeah. There's one more thing.
interfaces like
Yeah.
flat and
Yeah. Very
it's like
important thing. One word you're not saying, Dr. Banerjee. Like this. Come on.
Tangential section.
yeah, yeah. They are different. Like there is no
Okay.
commonality.
Yeah,
All are no epithelial
all
features.
are all are
Radioepithelium like there. Like stands because of the tangential cutting of the sections.
okay.
Yeah. Lot of connective
Tangential
tissue
is
codes.
fine. Tangential is fine. There are some flat epithelium also. All
Yeah.
are non-keratinized. Okay.
Okay.
I was looking at that word. Okay. So,
There is
clue for
one
histopathology.
response by Dr. Nidhi Yadav that it's arcading epithelium.
Okay, that is
Thought
also perfect. Arcading, perfect. We can take that. 3 cases were like that. So, clues for histopathologic appearance. How do you do that algorithmic? How do you have the formula? So once you put the slide under the microscope, you think of, is it keratinized or non-keratinized? Is the epithelium having plaque-like thickenings here? Epithelium having metaplastic epithelium like mucosa or cilia lining? Are you not seeing the lining at all? If you're not seeing the lining at all, have you missed embedding properly? Have you appreciated the lining in the gross and it is not seen here? Okay, you have to be always in the game and don't give this work to somebody and don't be bothered. वो करेंगे and I'll be like seeing under the microscope. Doesn't work like that. Okay, if somebody else is doing them, you should train them. You should give them instructions. Instructions is the key. So non-keratinized epithelium, developmental cyst, which has a very like a flat lining, like a reduced enamel epithelium like lining, is a dentigerous cyst. Again, it's a non-keratinized developmental cyst with ameloblastomatous lining. Unicystic ameloblastoma, which is considered as a tumor. Calcifying odontogenic cyst, which is the dentinogenic ghost cell tumors cyst pattern. Then inflammatory, you have radicular, you have your paradental, and you have your mandibular buccal bifurcation cyst. Okay, these are, you can put them under the heading. Okay, but there is something else that happens also. Okay, so this was the case. I had asked a question, and radicular cyst, 11 out of 22 of you responded. Excellent. This one, you had an arcading pattern there. It's a non-keratinized lining. I know these are poor, not very beautiful histopathological photographs. Okay, I apologize. So this is the radiograph. It's an anterior maxillary. This is the most common cyst that we get in the jaws. Okay, and radicular cyst is most common in your anterior maxilla, and most of the times you'll have a history of trauma or there is dental caries over there. Okay, it's almost 48 to 50% prevalence. When you take odontogenic cysts that you have reported over a period of time, you just check it out. You'll get some beautiful prevalence studies. This is the most common one. Okay, you should always correlate with the non-vital teeth. Okay, here we can see something, broken teeth. So other areas in this one, there is abscess within the epithelium that you can appreciate. It is a mature fibrous connective tissue wall. Okay, so we diagnose this case as radicular cyst in relation to 1, 2, 1, 1, 2, 1, 2, 2, and 2, 3. Any doubts, please put it on this one on the chat box. I'll be coming back to the questions. I know you will get a lot of questions sometimes. You might not agree with my diagnosis. I'll encourage you to do that. Question me. Okay, we'll discuss. So this is another case, a 10-year-old female patient with a well-defined radiolucent lesion in relation to unerupted 3-5 region, deciduous tooth, 7-5 showed deep dental caries. Okay, again, radicular cyst took a lot of, you thought of it. That's a great thing. Okay, but look at here. Okay, there is this decayed 7-5. Then you have an impacted 3-5 or an unerupted 3-5. Then you have this cortical plate thinning and buccal cortical plate expansion. Okay, not much on the lingual side. On one side, you can see it's very obvious. And you can see that this is somewhere associated at the neck of the tooth. Okay, and radiograph, you will not know where the lining is coming from. Okay, you can never judge. Always talk to the surgeon. And when they submit it, you can also see some attachment at the neck of the tooth. Okay, the other areas were like this. Suddenly, if you look at it, oh my gosh, this looks like stellate reticulum-like areas. What should I do about this case? Okay, see, you have, it's quite an aggressive lesion for a 10-year-old female patient. Okay, but the most important thing I'll be telling you is you can see some difference. This is another this after this we diagnose this as an inflammatory dentigerous cyst in relation to 4-5, impacted 4-5 or unerupted 4-5. Okay, the thing is all of you should know is there is inflamed DC, there is inflammatory DC. Okay, inflamed DC is still it has those RE, reduced enamel epithelium like areas, and there is a lot of inflammation there. But it is a typical third molar area that has happened. Here, the inflammation that has occurred at the periapex of a deciduous tooth, it has triggered the dental follicle. So it has triggered the dental follicle, which is starting to expand, and it is typically associated with premolars. Just check the literature. Inflammatory DC, what is it? Understand, it's a beautiful thing to understand, and how an inflammation can trigger a cystic lesion. Okay. See here, if you look at this lesion, the photomicrographs here.
Sir, I have a question.
Dr. Abhishek, can we take it at the end of it?
Yeah, sure.
Thank you. So, here, the lining that you see, the basal cells, okay, they're not hyperchromatic. In this particular case, you have a hyperchromasia right there. And this looks like a stellate reticulum-like areas. Okay. And here also, this is a very bad photograph. It's an old case of mine. And one more thing is, in this case, there was bicortical plate expansion. There was some thinning about lingual plate as well. If you compare it to the opposite side, just compare, and there is also breach in the cortex. Okay, by thinning of both the cortex. So remember that whenever you have confusion in histopath, go back to radiograph, go back to the gross, correlate. It has to form a story. Okay, in this case, okay, we had intraluminal areas. We did call it a unicystic ameloblastoma because of this hyperchromatic basal cells and stellate reticulum-like areas. I'll try to get better sections and share it with this one at the later point of time. What I want to highlight is always look at Vicker and Gorlins criteria. Okay, when you are confused, when you have a case of a dentigerous cyst like this in areas appearing where you have stellate reticulum-like areas, look at the basal cells. Okay, you should have hypochromatic nucleus, you should have reversal of polarity, but sometimes this is also missing. When there is a lot of inflammation, inflammation plays havoc in cystic linings. You should always go back and forth and give it a writing such that you have to, the doctor also understands that he has to be careful looking at the lesion. Okay, so Vickers and Graulin's criteria. Hypochromatism of basal cell nuclei. This was given in the year 1970. Basal cell palisading with polarization, which is referred as reversal of polarity, means it's gone away from the basement membrane. If you look at trace the basement membrane here, the nucleus are away from the basement membrane. Basal cell palisading with polarization, which is referred to as reversal of polarity. Cytoplasmic vacuolization with intercellular spacing of the lining epithelium. Again, that appears like a stellate reticulum, this vacuolization, and when they move away, they appear like stellate reticulum. If you look at these, and also you see sometimes the basement membrane having a nice hyalinization below. Okay, these criteria comes, you can easily call it a unicystic ameloblastoma. And in calcifying odontogenic cyst, I don't have this case with me, which I'll be not presenting. You get host cells and areas of ameloblastomatous lining. Okay, this is how you diagnose the non-keratinized epithelium. Okay, when you get confused, if you see stellate reticulum-like areas, always come back to Vickers and Gorlin's criteria and look at the radiographs. What kind of expansion you're seeing, what kind of lining you're seeing, how is the cyst appearing. Okay, so these are the things that you have to correlate. This again is a intramural spread. You can easily make out that these are hypochromatic basal cell nucleus and the superficial one looking like a stellate reticulum like areas. Okay, now this is another case that I presented. 30-year-old male patient presented with a well-defined swelling in the anterior palate. So all of you, because of the location and the lining, you have most of you have given 7 out of 22, and some I really appreciate, being honest. I cannot appreciate epithelial cells, incisive canal cyst. Again, it could be that it is a soft tissue variant of a nasopalatine duct cyst. Okay, here is the lesion. Unfortunately, what has happened is the doctor has taken IOPI, seen a lesion, and straight away done the root canal. He started off his procedure and waited, and this is not reduced at all. And then he has called, removed the, clean the canals again. Then he has called the surgeon that this is not at all reducing, do something about it. So the surgeon removed the cyst and submitted for the histopathological examination, and nice vascular neural areas can be appreciated. Okay, neurovascular bundle should be seen with nasopalatine duct cyst, and the teeth associated should always be white. Okay, so this was what we have done. Surgical history, site and above histopathology, a diagnosis of nasopalatine duct cyst in relation to the anterior palate. Most of the times, whenever you get radicular cyst, you see it coming to the buccal aspect, rarely going to the palatal. And if at all there is abscess that goes, it can go to the palatal aspect. Okay, because the distance of the periapex is closer to the buccal bone. Okay, here in this case, there was an obvious thing that this lesion is not going away. There is something else. Okay, and when the clinician went into the tooth, tried to do a root canal without doing a vitality test, he did find the pulp tissue being healthy over there. So you have to be really careful, educate your clinicians regarding this case. Again, coming back to the thing, initially we discussed non-keratinized epithelium. I showed you a few cases where we discussed about ameloblastomatous lining and the lining of radicular cyst where you saw arcading. Then the reduced enamel epithelial lining I did not discuss because it's a very common thing that you guys see in dentigerous cyst. I just showed those cases which are a little bit doubtful, where you can take your clinical radiographical correlation and then give a diagnosis. Okay, coming to the next one, keratinized epithelium. Here, I had submitted this one case, and 16 out of 22 guys, all of you you gave this case. And there was one they gave a comment that attempting without radiographs and proper history is very difficult. Absolutely right. Okay. This is the way you have to approach cyst diagnosis. Don't give a diagnosis if they don't give you a clinical details, or just you can write your differential diagnosis, make a standard thing saying that if this is this, this is this, this is this. Okay, these are the criteria, but still you say you can't give it on paper. You can describe it, and you could say that it's an odontogenic cyst, non-keratinized odontogenic cyst, developmental question mark, inflammatory question mark. You need to know the actual clinical history radiograph to give a proper diagnosis. Okay, so the other pictures are like this. It's a very beautiful case where there is no red edges, and you can see some amount of there is microcorrugation that is happening towards the keratin layer here and all. Proper parakeratin you have, and one thing that you're seeing is there is basal cell hyperplasia that you're seeing. Okay, can anybody unmute and say in OKC, if you see basal cell hyperplasia, you want to think about anything else? Want to give more information to the surgeon? Okay, anybody? Okay, just check, ask them to check the palm and the palmar and plantar, these areas. Ask them to check those areas. Okay, you will get some amount of pits here in this patient. It is poorly defined. Very few of them I could see in this patient. I had called them to the clinic and I could make out, because this became easy because there was a positive familial history, presence of sparse plantar splits and plantar neva in the patients. Positive family history means the patient's mother was diagnosed with Korlin-Gott syndrome earlier itself. Okay, so I wanted to ask them to, and this patient, the daughter had come with the lesion, and this is what I wrote them and asked them to get the PATH gene mutation, and also there is genetic counseling that we have to do, and there's a lot of penetration to the next generation as well in these lesions. Okay, this is also like that. In this case, there is a little bit of inflammation, there is red-ridge formation, but there is parakeratin and some amount of budding I could see. Okay, but in this case, you had multiple cysts. The previous case, this one. In this, it was a single cyst in the mandible. Here, in this case, it was multiple. It was there in the maxilla as well as the mandible in this unerupted developing third molar. You can just see how it is. It is huge cyst on all the four quadrants. Okay, and if you see the palm, definitely these are the pits. Okay, it is one of the diagnosis that you can show your hands and tell the diagnosis. You can say, like astrology, you're seeing pits, then you can be really careful. Okay, here this is another variant of the cyst. Now the classification, they put orthokeratinized odontogenic cyst and OKC into one label in 2022 WHO, this one, but the recurrence rate is quite less here. Here 5% is the recurrence rate in this. And the most important thing is you don't see a nice basal cells to be hypochromatic, and you can see a nice layer of corneum here. There is this keratohyalin granules that are very, very prominent. This both are clue for OOC, odontogenic, orthokeratinized odontogenic keratocyst. The follow-up will be same, but as per literature, the recurrences are little less previous literature. So this was what was given. This was an old report. In 2013, I reported it. That time we used to call it KCOT. There are areas where in the same cyst you can have orthokeratinized areas, parakeratinized areas. When it is like that, always we should go with parakeratinized areas and call it as a regular OKC. Obviously, we called it as KCOT, but no more the term is used. It's confusing. If you look at again, go back to the contents of Schaefer, this all comes under one. Even the blue book says neoplastic lesions of jaws or tumors of the jaw. In that only cyst comes. Cyst is more, it is not as others, like ameloblastoma is considered benign and locally aggressive tumor. Cyst is less aggressive growth or expansion that occurs within the jaws. Okay, the treatment is less aggressive. That's why the word cyst is used. Okay, which is stayed means with the surgeon who's treating. This has kept in their mind that they have to treat it with less aggressiveness. But OKC is well established term where a lot of um, recurrence are seen. Recurrence can be up to 20%, but I work with a wonderful group of surgeons. They're from Kiran Mazumdar Shah Cancer Center, where craniofacial department, there is Dr. Samarth, Dr. Paul Salins, and there is a superb doctor called Prashant. He has recorded over a period of time, whenever the OKCs are treated well with proper corticotomies and cornoid solutions and proper follow-up. Yes, very good cases where there is complete bone formation. It is how we treat these cases also. Okay, and the lining, everything gives a lot of clues when you're doing OKC grossing as well. This is another case which I sent for just for an interest. 21-year-old female patient with a swelling over glabellar region. Okay, so 10 out of 22 were no response. Here also cannot appreciate epithelial details. Absolutely correct. There was a diagnosis of dermoid and epidermoid. It's a common location. Glabella is right here. Okay, between the two eyebrows that occurs. This is the cyst. I got proper cyst, but the patient had pain, and the patient used to always do like this and always press it and play with the lesion. So whenever there is some kind of trauma or always there is an inflammation that keeps happening over there because of this continuous irritation of the lesion, you tend to lose the lining. Okay, there is inflammation. Inflammation plays quite havoc, removes of the lining. You can see some amount of giant cell reaction. Whenever there is keratin dissolution, you see this giant cell reaction. There is this 3D reconstruction. You can see that the near the forehead, near the glabellar region, it has gone in and slightly there is erosion of the bone that has occurred. Okay, so we called it an infected epidermoid cyst, sans epithelial lining in relation to glabella. Mainly, I have written here according to literature, where in infection or inflammation, there is tendency to lose keratin, and presence of keratin flake should have been there because they had also done a lot of initially aspiration. There could be a lot of inflammation triggered on that only, where they have not got a diagnosis. Then they have gone and removed this one. So whenever they try an aspiration, you also discourage your surgeons. Okay, when aspiration is done, you tend to disrupt the lining sometimes, and you tend to induce inflammation in the lining, and sometimes you lose it. When it's a very huge lesion, ask them to take a good chunk of it from multiple location and give it to you. Okay, mucicarmine was done, it was negative. So now I want to talk a little bit about inflammation. Inflammation is the one that can also make OKC lose its keratinization, and it can make dentigerous cyst lining resemble a radicular cyst lining. Okay, and this has been recorded in a lot of textbooks as well as in articles. You should always be careful about the connective tissue wall. If it has a lot of inflammation, then 1 minute, I'll just
Dr. Badranna, you are on mute mode. Please unmute yourself.
thank you. Sorry, some patient walked in. I had to tell them I'm not working right now. So inflammation is the one that you have to be really careful as to look at the lining, what you're seeing, okay? And radiographically and looking at the size of the lesion, the clinical symptoms, you can always suspect something else, something cynical, okay? There are many things that can give clues to you. One is the clinical history, gross, and radiograph. Sometimes when you remove the bottle, the specimen bottle container, you can see keratin floating on the formalin. Okay, that is also a clue. Then you can have these white chunk areas. These all can be flecks of keratin. If you're not able to see a proper keratin lining in this, because there is a lot of inflammation in this area, these can be correlated and say that we might be looking at a OKC here. And typically, OKC lesions are the posterior most teeth is, you see a radiolucency in your ramus associated with the distal aspect of the impacted teeth. And you generally see an anteroposterior growth pattern, and you see sometimes crossing the midline. Okay, all these are clues that you have to be very careful. If you see cortical plate expansion and a small lesion, then think of something else. Okay, and if you see only buccal plate expansion and you're not able to see the epithelium, think of dentigerous cyst. Okay, but write a note that this is the problem with inflammation. There is a word called synequinon for diagnosis of radicular cyst is related to presence of a tooth with a non-vital pulp. Occasionally, a sinus may lead from the cyst cavity to the oral mucosa as well. This is a classic sentence. It's a screenshot taken from Marvin Schaefer. Synequinon is an essential condition, a thing that is an absolute necessary. If there is no non-vitality in the associated teeth, especially at the periapical lesion, think of something else. Okay, I put this one so that you have clinical radiographic correlation. These are the most important things that you have to do. Okay, again, coming back to the algorithm or the classification, epithelium with plaque-like thickenings, you have lateral periodontal cyst, botryoid odontogenic cyst, gingival cyst of adult, and you'll also see this in glandular odontogenic cyst. Okay, in my case collection, I don't have these lateral periodontal cyst and very beautiful looking. This is from this article. Basically, my whole presentation is based on this article. Strokov et al. Beautiful article. I'm going to share it in the group, and you can DM me also. I can send it to any of the social media platforms so that you can read it yourself. This is the botryoid odontogenic cyst. You will see a lot of daughter cyst. Okay, multilocular, and each of them, these are the plaque thickenings, almost their whirling pattern that you see in the epithelium. Okay, these are typically seen in these 4 cysts. Okay, histologically, these are your clues to think in these directions. Okay, if you look at it, all these topics are in itself a seminar. A lateral periodontal botryoid odontogenic cyst. If you look at lateral periodontal cyst, radiographically, lateral surface between 2 teeth, it appears. Gingival cyst of adult, it is a soft tissue component of lateral periodontal cyst. And the keratinized epithelium we spoke of, right, previously, there is something called gingival cyst of newborn. These are the soft tissue. You have a lot of white ones. You need not to treat them. If they come to your OPD, send them, it will go away on its own. Okay, so this is the plaque-like thickening that you have, and these are the classic clues of these lesions, these 4 ones. Coming to epithelium with metaplastic epithelium, mucous and cilia, generally, if you see a dentigerous cyst, dentigerous cysts do have that reduced enamel epithelium can give rise to those metaplastic changes. It proves the pluripotentiality of odontogenic epithelium. Also, radicular cyst, if it is in the anterior region, it can get something from the nasal floor. If it is in the posterior region, it can get some contribution from the maxillary sinus, and those changes can be seen. And there is something called surgical ciliated cyst in that region that can have these metaplastic epithelium. I have not included that here because that becomes another discussion. Okay, so this was one of the cases that I had shared, and out of 3 out of 22, you called it a dentigerous cyst. Little difficult to call dentigerous cyst, right? There's a lot of hyperplastic epithelium noted, and you have some daughter cyst that you can see in the connective tissue. There is a beautiful response, MEC arising in the epithelial lining of dentigerous cyst. Excellent. Somebody called it an ameloblastoma. Okay. UA mural type, I accept with that magnification. This case was a beautiful case way back in 2013. You can see mucous metaplasia, there was cilia there. Okay, some amount of plaque-like thickenings in areas that I could make out. And you had these daughter cysts that were deeply placed within the connective tissue wall. Okay, there was this varying pattern. In areas it was hypoplastic, and in areas it was very thin, but a lot of mucous cells were seen. This is mucicarmin, positive for mucous cells, beautifully taken up. And this is a classic duct-like area that you can see within the epithelium. Okay, this should be seen for you to call a glandular odontogenic cyst. You can see some amount of whirling pattern here with plaque thickenings. Okay, and if you see, it is a mandibular lesion. Again, it is associated with the neck of the tooth. Complete tooth was involved here. Okay, we had to call this lesion. There was expansion related to this lesion. We called it a glandular odontogenic cyst, and we had to be careful saying that MEC is one thing that can arise from this. We have to be careful. Follow up the patient a long time. Okay, coming back to again, when you don't get any lining. If you don't get any lining, one, you have to be careful that have you embedded the tissue properly? Yes, I'm confident I have embedded it properly. On the slide also, you can see it linearly being embedded like this, but still you're not seeing lining. Then think of one of the lesions within the jaw, aneurysmal bone cyst or a solitary bone cyst. In this case, I had given this. I was really happy. 6 out of 22 of you got it with just this clue that the lining had giant cells. Some of you got confused, called it COC. Maybe it looked like a giant cell, not giant cell, ghost cell. I give it to you, it's okay. Yes, giant cell, there was a question mark, CG. Excellent, I still give you points over there. Okay, so with this magnification, you could do this. So the lining was a fibrous lining with giant cells lining the area with like fibroblast, giant cells forming the main lining. And I generally ask the doctor, when you went inside, how was it? Was it solid lesion or a cystic? He'll say, no, doc, that was a cystic lesion, completely empty. Other sections, again, sorry for this one, I could not go back to the slides. These are like very old slides. When I was in college, these were reported from a private college. I used to do it with college that time. Cavernous spaces were seen, large areas. Again, you have these giant cells, very osteoclast in origin. Okay, you had bone also, but no, typically there is no epithelial lining at all. And this was somewhere here. Okay, a radiolucent lesion, and all the teeth were vital. Vitality is important. Keep asking about it. Okay, one is color, decay, proper proof that it is involving the pulp, and all of you, there is something called a cold test. There is a spray that comes, you put it on the cotton pellet and hold it against the tooth. And if the patient reacts to it, then it's vital. If the patient doesn't react, there's a way to do the vitality test. Maybe another session that we can do. This information we have to give our surgeons. Maybe if somebody is giving you a lot of biopsies, present them with that Coltein's frost bite test. Okay, it's a very handy thing the surgeons can have, especially when they're dealing with cyst. Okay, so we did give it as aneurysmal bone cyst of the left body of mandible, but we also gave this could also occur in ABC. Sometimes there is degeneration of CGCG, this giant cell reparative granuloma or central giant cell. There is cystification that occurs. It can appear like this. And it can also be a Brown's tumor associated with hyperparathyroidism. So parathormone were conducted. We didn't follow up the patient. Otherwise, I could have given more information about this case. This is a case where I clearly remember I was a staff, first year staff, and the pedo PG came with his eyes wide open. Sir, sensitivity of lower teeth was there. There is a little bit trauma maxillary teeth, and there is maxillary left central incisor is non-vital, sir, but all the lower teeth are vital, sir. I have checked the vitality over there, and I see a cyst. He was like so happy that he has discovered something, and he was explaining me so well. Okay, and he was like very surprised. Okay, and surgeon also, when they opened the lesion, okay, they also, very wide eyes, there was nothing. I had to struggle to get some tissue from there. Okay, it is how a traumatic or a simple bone cyst is explained. Okay, the persons who are involved, they're always surprised. With blood field, only blood was a blood day, sir, khali ittu. That's what they properly say. You can see this discoloration of maxillary central incisor. Okay, so this got published as well. I thank Dr. Priya Subramaniam, Krishna Kumar, and Ramakrishna sir was the surgeon here. They were to pedo department. I was from the oral path. We could diagnose this case as a traumatic bone cyst or / solitary bone cyst. Okay, and I had given few more cases. This was the one, and 4 out of 22 people got it got this as unicystic ameloblastoma. Okay, a better image could be shared because, like, this lack of time, I have not shared many images. You can see proper that basal cells are hypochromatic. Okay, the superficial cells sort of resemble stellate reticulum like cells. A higher, this one would have given us more clues. This was a 19-year-old labial mucosa and mucus extravasation phenomena. 14 out of 22 of you got it. This case, we'll come back to this case again. I spoke about processing, fixation, and everything. Here, radiolucent swelling with cortical plate thinning and involves both 4/7 and 4/8. Okay, look at the extent of the lesion. I should give a report, right? With this, I should tell something to the patient, right? Or this should be done for this patient, or do a second biopsy with more details. So we said that because I showed you the video where it was attached at the neck of the tooth. It could be dentigerous. We wrote it like that. Collaborating with the radiographic findings, association, cervical aspect of developing 4/8, and prominent expansion only on the lingual cortical plate. Gross feature probable diagnosis. Before sending, we write probable word, but we call the doctor before sending the report. You should not be shocked. What are you writing probable here? You should say we are writing probable because of these things. Okay. However, possibility of OKC also cannot be ruled out. Kindly follow up the case. Okay. Then we got, they did the enucleation and submitted it to us. Unfortunately, it was a mural ameloblastoma, unicystic ameloblastoma with mural proliferation. We just wrote it, managed the abolition like a conventional ameloblastoma. So this is the difficulty when you get the things wrong. If there is something going to be wrong, it's going to be a real mess for the patient. So it is a difficult thing. If something happens, recurrence occurs, we should make the patient be prepared of this. And our report also should be medico-legally. You should protect yourself. Okay, we did write that this could be anything else like an OKC also, probable diagnosis. We have written there, right? So this article I'm going to share anyways, but this is a checklist that you should always ask. Identity of the patient, name, age, gender, ethnicity, medical history. You can correlate to that. Historical data of the lesion, duration of the lesion, previous recurrence, family history of jaw lesions, that where that nevode basal cell carcinoma comes over there. Symptomology, swelling, yes or no. Then pain, paresthesia, adenopathy, vitality. This is most important. Okay, impacted tooth, inflamed tooth. What is the clinical, the chief complaint? All those. What was done? Curettage was done. Incisional biopsy, excisional biopsy, FNAC. Then radiological data. What was the radio density? It is better to ask them to share the report with them. There's a lot of thing that oral pathologists publish of the case. Go and give them confidence. I'm not going to do anything like that. It is cheap on me to do without your permission. You have done a lot of for this case. If we have to publish, we are going to do it together. Okay, or have an MOU saying that I'm not going to do it, but I'm going to report all the cases for you. But for me to report, I need the information. So I had a surgeon saying, a very senior surgeon saying, previously the pathologist never asked for details. Maybe, I don't know, why didn't they ask for details? I'm not as good as them, but I need these details. Okay, somewhere the surgeon also needs to know that without the clinico-pathological correlation, we will not give a good diagnosis. Okay, anatomical relationship, where it was. Okay, so sinus floor, nasal floor, you can see the changes, cell changes, you can correlate to them. Okay, dimension of the lesion. How was the margins? Unilocular, multilocular, moth-eaten appearance. Okay, all these you can see. It's best to have a beautiful relationship of pathologist and the surgeon. Okay, what happens here is the patient is going to be happy. That's why there are tumor boards, even where the pathologists are also part of it. They're going to give justice to the patient. Okay, so my gratitude to my referring surgeons, Saman Shetty, Dr. Prashant, Dr. Kaushik, Dr. Kishan Panikar, Dr. Murlidhar Nagarjuna, Dr. Akshay Shetty, and many more people who send those cases. Gratitude to my teachers, TV Narayan sir, Liki Mohanty madam, Sadhna madam, Manjunath sir. He's from oral medicine. He taught me why radiology is so important. Then I work with Sharda ma'am and Priya ma'am. I keep learning from them day in and out, and we have collaborated with Oralty, which is headed by Dr. Vinod. Okay, thank you to POPMA and the study club, Dr. Bhuvan Nagpal and team, and all the participants today. Thanks for this. I would like to end with the image of this. Can all of you tell me what does it, what clicks in your mind when you see this? What does it resemble? None of you. Come on, man.
Some cellular material forming a tissue.
Okay, perfect. Doctor, soft tissue. Anybody? Wow, Anita Florence, enamel prisms, honeycomb. Excellent. I really like, hats off to Dr. Anita. I was flabbergasted. I was there on this place on Wednesday. This is a St. Mary's Island. Okay. It is a beautiful island. Somebody was taking a drone shot. I went and asked, can you share the image? He shared this to me. You should go to Mangalore. Okay. And you see these rocks, you are going to be shocked. They look like enamel prisms. Okay. Somewhere geology and hard tissues in our mouth are very closely related. Studying both of them, you can really think of it. Okay. Okay. Tortoise, abnormal cells, accepted. All that is accepted. So thanks again. What I wish all of you is curiosity. Okay, you go to any place and you really like something, or it's always there. You correlate stuff. Cyst is like that. You need to correlate something like a real life. This one. If you're really passionate, no, you see things in everything. Okay. Thanks for the opportunity again. I'll stop sharing now. I'm open for question and answers. And yeah, I finished at 4 o'clock. I think so. I've taken 10 minutes more.
Yes, yes, sir. It was indeed a very insightful lecture, and yes, lot of answers were there: abnormal cells, epithelial cells, honeycomb, enamel prisms, tortoise,
Yeah,
cobblestone.
absolutely. Absolutely.
But yeah, so cross section. I think we'll take the question. Dr. Gauri, are you there? Okay. Sir, her question is like how to differentiate inflammatory dentigerous cyst from dentigerous cyst transforming to OKC.
Okay. Okay. I have not personally come across a case where DC goes to OKC. See, inflammatory cyst, they'll not be keratinized. Okay. OKC is keratinized. Okay. Basic is that. And you're going to see keratin. And rarely an inflammatory cyst, you see keratin means whenever you see this arcading pattern that comes. Okay, if it's at the periapex and it's non-vital, you think of radicular cyst. If it is a pericoronal radiolucency and you have a single, like there is a cortical plate expansion only on one side, and you see that inflammation, and again you see arcading pattern, you can think of DC, or it is only on the distal aspect, partially erupted tooth, then it's a paradental cyst. Okay, but the difference between DC transforming into OKC versus inflammatory DC. Inflammatory DC does not have keratin, doctor.
Correct.
Dr.
Dr.
Banerjee
Abhishek.
wanted to ask me.
Yeah, Dr. Abhishek Banerjee, are you there? Dr. Abhishek Banerjee, I think he's not there. He had question at that moment for that particular case. Any more questions or Any comments or any feedback anybody would like to share or speak?
I think so. Your people are not able to unmute themselves. Dr. Varsha has written here.
No, now it's done. It's already they can unmute. Everyone can unmute now. In between, because people were entering, so a lot of disturbance used to be there. So I changed the setting. Now, anybody wants to ask any question, they are most welcome for that.
I hope I gave some thought process to how to approach a cyst. I hope that I have done. It is very difficult to fit it in 1 hour and also show cases. I felt showing cases and you being part of that Google Forms will actually give us a lot of
Yes.
answers, and the
No,
discussion would be like that.
that was actually a very good thing, and I think no comments or no further questions are there. So one comment I would like to make, like as you rightly said, that that proper fixation, proper processing, all these things are very important for all the things. So again, I'm repeating, in one of the sessions I have said, don't accept any specimen which is not given informally, because it will land up into a trouble which will be irreparable. That's my stance. So this is my take. What is your opinion, Dr. Badranna? And I think welcome, ma'am. Good evening.
Good
Shraddha
evening,
ma'am is
Bhuvan.
here with us.
Yeah, Abhishek, that was a very comprehensive and insightful lecture. And I have always loved the enthusiasm you show towards the subject. And working with you and Priya, that enthusiasm has come back again to me, which I had lost for a few years, 2 or 3 years, due to some reasons. But Abhishek, that was great. And every slide had something to learn. And your explanation was very clear. Very good, Abhishek.
Thank you, ma'am. It's
So
like really like
it's
humility from Sharda ma'am whenever she tells
yes,
like that. It's a big learning for me that staying humble is the characteristic that for greatness. So
yes. And
thank
a
you,
lot
ma'am.
of other appreciation thoughts are there from Dr. Sondarya, very informative lecture. Yes, thank you, Popma. Yes, we are trying our best to spread the awareness and other things. Then other people also, Dr. Nandini, madam, she's saying nice presentation, Dr. Arushi. Then one question is there
Vikram.
by Dr. Vikraman S. Same cystic lesion received at time gap of 2 weeks. First one is diagnosed as unicystic ameloblastoma. Second one does not have such ameloblastic changes. It looks like dentigerous cyst. Is that possible to have a lesion with such a difference?
Uh, Doctor, what I would say, those lesions that has unicystic ameloblastoma appearance may be given you at the level of incisional biopsy itself. Okay, first you should make sure it is the same patient and everything. Okay, make sure it is the same thing. But if those are seen in your incisional biopsy, then your management also should be a unicystic ameloblastoma itself, not a dentigerous cyst. You should say that these are seen in incisional. Excisional looks like DC, but this should be managed like UA because I'm seeing these cases in incisional biopsy. I had seen a case with Narayan sir that they had given us incisional biopsy. It was a HIV positive patient. We could diagnose it as a squamous cell carcinoma. Okay. Then they did, it was T1 lesion, less than 2 centimeters. But all the nodes were positive from the occipital nodes, everything was positive. When they gave the excision, in excision there is no squamous cell carcinoma at all, but only in the lymph nodes it was there. So we had to write in the report, sir did write that the whole squamous cell carcinoma was taken out during incisional biopsy, but an excision was necessary to look at the margins, but these things happen. Incisional biopsy, you got the UA area, you have to manage it like that. It is possible. There is he used to always say, Rangnath sir, and I used to attend his lecture, right? Narayan sir, these lesions don't read textbooks. So
That's correct.
it's what it is. It is what it is, sir. Vikraman, that was a good observation. Yeah.
Yeah. And then I think Dr. Arushi ma'am, you wanted to say something? Are
Yeah,
you
yeah.
there? Yes, ma'am. Please go ahead.
First of all, a
Good to see
lovely
you.
lecture.
Thanks, ma'am.
Very, after a long time, managed to come back to the POPMA platform, and yeah, very interactive. I really like the concept of the small Google form. It really charged up my PG brains. I separately mentioned also. It was very
Yes.
nice and very well explained today. I just want to ask, like sometimes we get specimens where we just get small bits, no lining seen, inflammatory capsule is there. So
Mhm.
can we just leave it at a diagnosis of a cyst or perhaps a odontogenic cyst and leave it to that? They say they have enucleated it, but still we just don't find anything where we can specifically say what type of cervical teeth are there, everything is there, but no lining anywhere. So leaving it as a cyst, an explanation would be good enough, or
Mm.
how do we go about those?
Wha- Our report should protect us medico-legally. I feel this should have a lot of explanation and saying that no epithelium is noted here. We should also make sure the embedding is fine. We try to re-embed it again. We look for the cyst. We have to do all our homework and finally say that lining is not seen. And we should have a word with the surgeon saying that radiographically this looks something else. It looks very classical to be a
Just leave it.
dangerous cyst or a UA unicyst. We can look at the age also, ma'am. Okay, and it could be this. And did you see
And
any
secondly,
cheating
the fluids which we get, what all should we report on that? What all points should we report once we get the fluids? Like many times we get those
aspiration
fluids
fluid?
first, and what all points should we do in that?
Ma'am, I have seen when we get a fluid, whenever we see foamy cells, no, most of the times it is a radicular cyst. That foamy giant cell, foamy macrophage, it's a big cell when compared to the other lymphocytes which are there. If you're looking at that in the aspiration, I write that this one, but I always say that this is not a pathognomic thing for any
Correct.
lesion. Aspiration can't
So
give you
do
a
you
final
go for
diagnosis.
biochemical analysis as like find out the protein level so that we can
Okay.
have an idea like it is an odontogenic or a inflammatory cyst? Do we go do those processes also if we get it, or just a microscopic look because much will not be seen there? So do you recommend a biological biochemical analysis of the fluid?
Ma'am, generally,
Protein analysis.
if clinician asks for it, no, ma'am, I do it, ma'am. On my own, I don't do it. Okay. And I generally avoid if somebody is telling I'm sending you aspiration, I say don't do it. I'll not be able to give you a final diagnosis. If you give it along with the incisional, I can say something. Otherwise, I'll always say, this could be this could be that.
No,
But
and
in such
things like
things,
culture and sensitivity, they would ask, could you please
mm,
do culture and sensitivity of the fluid? So,
mm.
such like what would be, how do we handle those situations? What
In
all should
culture,
be done for?
if they ask for it, get it done, ma'am. Get the lab done. And
Yeah.
generally, anaerobic culture is difficult. Once they send it through transportation, it has already been exposed to oxygen. Will not be. We can say we'll do aerobic culture and see which is the sensitivity antibiotic that you can give. I think Dr. Bhuvan, you want to add something?
Yeah. I wanted to add. First of all, ma'am, anaerobic culture is actually very difficult, and majority of the labs they don't do. And because I do a lot of fine needle aspiration cytologies, so in my opinion, it is actually non-diagnostic. It's better to go for histopathology. That's a gold standard for odontogenic system. It can be a misnomer. It can added advantage, but you should not rely entirely on that.
No,
For
because
other
many
sorts
times they said,
of
Madam, we are sending the cyst fluid first. I was like, no, it is really
no,
sometimes so, but I can say, I can just
we
say
have to educate the
cheesy or
surgeons, ma'am.
something like that. Nothing very great can be, but then I was thinking, do we have some like, now go with a biochemical analysis or something like we have a analyzer. So if you do a total protein,
But
just to
again,
find
ma'am, that will not be the final
that will
dictum.
not
That
be
yeah. The final thing will be the histopathology lining and your
line.
radiograph.
Yeah,
This is
obviously.
my take, and I think Dr. Badranna also agrees that because the fluid will give you a non-specific picture, and it is not dictamized,
Not
pathognomic
because many
or
times they just send the fluid, like, can you do the analysis or can you do? I was like, what is there any
advise
format or something?
biopsy and histopathology.
Okay, that would be just
Because
And protein analysis, ma'am, there is correlation for OKC only.
yeah,
Is less
that is the thing.
than,
Correlation.
so there is OKC only, but
OKC is
generally,
good.
again, if it's OKC is again his inflammation is there, again you can't say. You can say if it is inflamed, again this also can be OKC, even though it is the higher. We see about albumin and globulin. The lining is so thick in OKC, there is a parakeratin. It does not allow the intercellular fluid to contribute to the cystic lumen. So when this albumin globulin doesn't reach there, you don't get a higher value in OKC. But if it is again inflamed, we lose keratinization. So we can't give a proper diagnosis. That's a problem with
So I
cystic.
generally go and see it under the microscope as to see what it is, because one case there was of scrofula that did help in the diagnosis of the case when they were having like now there is a cystic lesion and they just did the aspirate of that. It turned out to be a scrofula. So
Mhm.
I leave it up to like now I just see it under the microscope if something is go and I just leave that point.
I think so.
It,
Dr. Vidhi and Dr. Kiran wants to speak. You can please unmute yourself,
Mm,
please. Ma'am, Vidhi,
Yes,
ma'am.
ma'am, Arushi ma'am, in relation to your question, many a times what we have seen is, even if it's an inflammatory, odontogenic cyst, if in case it is infected by any reason, in that case, that protein estimation comes very non-specific. Like we have
again,
seen few cases
very
where
true,
the
very true.
enthesitis cyst or OKC were also having, values fluctuating. Matlab it was not specific though. So
because
probably I
exudate
also
will
feel
come
that it
out.
is not so
It will be
important.
exudate. So
Yeah,
it
Yeah,
will anyways will be high,
it will be
non-specifically.
high. It will be high.
non-specific.
It
Right.
comes high. You theoretically we say for OKC it has to be less than 5, but we have seen 2-3 cases where FNAC was sent and it was more at a higher end because don't know which area is infected. Many a times it is there, infection is there. So that is a little non-diagnostic as of like our experience also.
Right.
Correct.
Thank you so much.
Dr. Shelja, ma'am.
Yes, Bhuvan.
Yes, ma'am. Please go ahead.
So
You
now
want?
we have come down to Toller's hypothesis. So Toller's hypothesis will only differentiate by looking at the cyst, which is actually having an odontogenic origin. Inflammation shouldn't be playing any role. So if you get, that is the basic of protein estimation. Nowadays, when you look at the fluid estimation, you're basically trying to prove the Toller's hypothesis, and it is true. What in addition, what can be done is the C-reactive protein estimation in these cases, which will help to give a plus point to the diagnosis. That is I usually do when there are a lot of expensile cases for a small lesion. So that is my point that I wanted to say.
Yes, correct. Again, can be taken. Uh, mm, that's true. I think Sharda ma'am is there with us right now. Okay, then Arushi ma'am, you only do the honors for Abhishek sir.
Oh, oh, I proudly present Dr. Abhishek the certificate of appreciation. Thank you
You.
so much, Dr. Abhishek.
Thank you.
Yes, and I request everyone to put on their cameras. And like finally, the closing remarks on behalf of POPMA. I would like to extend my heartfelt thanks to Dr. Abhishek Badrana sir for delivering such an insightful and thought-provoking guest lecture. Your expertise, clarity, and the depth of knowledge you shared truly enriched the session and left a lasting impact on all the participants. Your valuable perspective on the diagnostic algorithm for the diagnosis of cysts of oral and maxillofacial region were not only informative but also inspiring, and we are grateful for the same. The time and effort you took to engage with us, it was truly an honor to have you as an esteemed speaker, and we look forward for so many lectures ahead. Thank you so much, and Ma'am, you are looking very much tired. Dr. Shailja, she got recently got surgery done, and so I'm seeing after a long time. So everyone, please put on their cameras. We can have a group photograph. Then we can. Oh, thank you so much, Nandini ma'am. You are there with us.
You're muted.
Very nice, Dr. Abhishek. Congratulations.
Thank you.
It was a pleasant surprise to see you.
I think, ma'am, your internet, yeah, there is issue sometimes. Yeah, the voice was breaking. So, any further suggestions anybody would like to make for or any topic you want for future? We can incorporate, because for the month of May it is now done, and we'll come up with the stalwart next time, and the regular series which already been there. And those who are interested, they can give their approval, so that everyone should have a chance of sharing their knowledge with everyone. So that is the whole and sole purpose of conducting POPMA study clubs. So thank you so much, Dr. Abhishek, and all the participants for joining us. So see you with the next POPMA study club, and stay tuned. You will be informed for the same. Thank you. Bye. And have a nice Sunday and weekend. Enjoy.
Thank you.
Okay.